Hi everyone. In this video, we'll just brush up on our knowledge of the temporomandibular joint. I won't be getting into the finer details and we won't be discussing the blood supply or the innervation. So it'll be a brief overview of the structural components of the joint. I just felt that it's important to understand the basic anatomy of the temporomandibular joint and the masticatory muscles so that we can understand the more difficult topics like mandibular movements and occlusion better. So here we go. We know that a joint is the connection between bones. So the temporomandibular joint is the connection between the temporal bone of the cranium and the mandible. The parts of the temporal bone that contribute to the joint are the mandibular fossa, which is this concavity right here, and the articular eminence in front of the mandibular fossa, which is this protuberance. The part of the mandible that contributes to the joint is the condylar process or the condyles simply. The TMJ is classified as a gangliomo-arthrodial joint. Now I know that's a mouthful, but let's break the term. So gynglimus, which is the first half of the word, means rotation, and arthrodial, the second half of the word, means translation. If I were to simplify it for you further, imagine that you were to insert a rod passing through the centers of rotation of both the condyles. Imagine that you were to hold this rod between your thumb and your forefinger and you were to twist the rod between your fingers. Now you will find that the mandible moves up and down about the axis or the rod that you just inserted. Now that is an example of a rotational movement. Imagine that you were to hold the entire mandible in your hand and you were to move the mandible front and back or from side to side. Now that is an example of a bodily movement or translational movement. So the TMJ is capable of both rotation as well as translatory movements, which is why it's called a two-in-one joint. Now, like all other joints, the articulating surfaces are covered with cartilage. But in case of the TMJ, we have fibrocartilage. So we know that fibrocartilage has a lot of collagen fibers, which gives it a lot of strength. Think about how much you use the joint. I mean, I'm using it right now as I speak, and we use it so much while we masticate. There's a lot of stresses that are being transferred to the joint when we chew food. So the joint needs to have a structure that is capable of tolerating this amount of repetitive loading and high stresses. So the fibrocartilage helps give the joint a high amount of strength and resistance to loading. A very unique feature of the temporomandibular joint is that it has an articular disc between the articulating bony surfaces. Now, as the joint goes through different motions, it has to go through these motions without friction and a lot of wearing off of the joints while being able to move freely. So, the articular disc helps in free movement throughout its range of motion and it also reduces the friction. We'll study this in greater detail in the upcoming slides. The joint as such is enclosed within a joint capsule. So these are the structural components of the joint: the bony articulating surfaces, the cartilage that covers these surfaces, the articular disc, and the joint capsule. Now, when we compare the bone in the roof of the mandibular fossa to the bone in the articular eminence, to be more precise, the posterior slope of the articular eminence, we'll find that the bone in the articular eminence is slightly thicker and more denser than the bone in the roof of the fossa, which is why the articular eminence is the functional articulating surface, meaning that forces are directed towards the articular eminence rather than up against the fossa. This is a view of the condylar process or the condyle of the mandible from the front. Now imagine that the condylar process or the head of the condylar process had a spherical anatomy. What would happen is that forces would be concentrated in a very small area, which would result in a lot of trauma to the joint. Now, this is not the case, thankfully. So, we have a more elliptical anatomy of the condylar head, which increases the surface area for stress distribution. Therefore, it reduces the trauma to the joint. Very important to remember. Articular disc is a very distinctive feature of the TMJ. Now, this is a view of the TMJ from the side, and this is a view of the TMJ from the front. Now we saw in the previous slide that the joint capsule encloses the joint. Now the articular disc is nothing but an inward extension of the joint capsule. So it is connected to the joint capsule both anteriorly and posteriorly, as well as medially and laterally, over here and here, medially and laterally. So now, for example, if I were to draw the joint capsule over here and over here, starting from the posterior, the joint capsule extends inward as the retrodiscal tissue, which is highly vascular and innervated, which again extends forward as the articular disc itself, which is made of fibrocartilage, and so it is avascular and non-innervated. The articular disc again anteriorly fuses with the joint capsule and some fibers of the superior lateral pterygoid muscle. Now, if we take a look at the anatomy of the mandibular fossa and articular eminence above and the condylar head from the side, we'll see that the anatomy of these structures gives the articular disc a biconcave shape, meaning that it is concave both towards the eminence and towards the condyle. So it is thinner in the middle area, which is called the intermediate zone, and it is thicker in the anterior and the posterior areas. Now, it's a very important structure. Had it not been for the disc, we would have pretty much worn out our joints by now. So, thankfully, we have this structure that helps in a very smooth and friction free movement in the joint, and it also acts as a cushion to absorb the shock. And because it's made of fibrocartilage, like I said earlier, fibrocartilage gives the structure a lot of strength and resistance to tolerate repetitive loading and high magnitude loading. Now, the articular disc divides the joint into an upper joint compartment and a lower joint compartment, like you can see in the white space above and below the disc in the frontal view of the joint. We'll discuss the significance of that in a while. Now, the articular disc can't be a freely moving structure. It has to move along with the condyle during various movements. So, for facilitating that, it is attached to the condylar head medially and laterally, over here and over here. So, these attachments are called discal or collateral ligaments because they help maintain the integrity of the condyle disc assembly and help the disc to move along with the condyle during various movements of the jaw. We saw in the previous slide that the articular disc divides the joint into upper and lower compartments or synovial cavities. So here we have the condylar head, we have the articular disc which divides the joint into an upper and a lower compartment, and we have the mandibular fossa and the articular eminence. Now I want you to do a little fun experiment. I want you to place your fingers in front of the tragus of both your ears and begin to open your mouth slowly. You'll feel that initially the condyle just rotates where it is. So this initial rotational movement of the condyle happens in the lower joint cavity, where the articular disc remains stationary. It does not move. It's just the condyle that rotates. Now, as you begin to open your mouth further apart, you will actually feel that the condyles move forward. What happens is that the condyle, along with the articular disc, slide down the posterior slope of the articular eminence to move forward. And this forward movement or this translational movement happens in the upper joint cavity. So this is the importance of the upper and lower joint compartments. The joint capsule is a fibrous tissue that encloses the joint. So it keeps the components of the joint together and in a way stabilizes the joint. So it's called the capsular ligament as well. Now, superiorly, it's attached to the border of the articulating surfaces, which is the mandibular fossa and the articular eminence, and inferiorly, it attaches to the neck of the condyle. Now, we saw in the previous slide that the articulating surfaces are covered with fibrocartilage, and the articular disc is made of fibrocartilage as well. Now, we know that cartilage is avascular and non-innervated. So the joint capsule is lined internally rather, by the synovial membrane, which produces synovial fluid. Now the synovial fluid is what provides nourishment to these avascular structures and fulfills their metabolic requirements. It also provides lubrication to help in a very smooth and friction-free movement in the joint. And the joint capsule as such also provides proprioceptive capability to the joint. Now, there's an anterolateral thickening of the joint capsule over here. It's not as prominent, but just for understanding purpose, it is called the temporomandibular or the lateral ligament. We'll see the function of that in a while. Speaking of ligaments, we know that they don't have a lot of give, so they passively help prevent the joint from going beyond its range of motion and help stabilize the articular system during various movements. As for the TMJ, we have three principal ligaments and two accessory ligaments, which we'll discuss in the subsequent slide. The three principal ligaments of the TMJ are firstly the collateral or the discal ligaments, which we saw connect the medial and lateral aspect of the articular disc to the medial and lateral poles of the condyle. So they help ensure that the disc moves along with the condyle during various movements of the jaw. The second principal ligament of the TMJ is the capsular ligament or the joint capsule because it encloses and stabilizes the components of the joint. The third important ligament is the temporomandibular ligament or the lateral ligament because, as we discussed before, it's an anterolateral thickening of the joint capsule itself. Now imagine that this were the mandibular fossa and the articular eminence, and this were the mandibular condyle. So the temporomandibular ligament or the lateral ligament would be somewhat like this. Now we discussed in one of our previous slides that upon initial mouth opening, the condyle rotates, and upon opening the mouth further, the condyle begins to translate forward. So what happens is that when after the condyle rotates up to a certain point, the lateral ligament attains its maximum length and can't stretch anymore, which is why to open the mouth further, the condyles have to translate forward down the articular eminence. And this is how the lateral ligament limits mandibular rotation on opening. We have two accessory ligaments, and they're called so because their role is not clearly defined. So it's the stylomandibular ligament and the sphenomandibular ligament. The stylomandibular ligament runs from the styloid process to the angle of the mandible on the posterior border, and it is said to limit extreme mandibular protrusion. Whereas the sphenomandibular ligament, which is over here, runs from the spine of the sphenoid to the lingula of the mandible on the medial surface, and it doesn't have a very clear role. So these are the accessory ligaments. And that will be it for today. Please feel free to pause the video and quiz yourself. You can find the answers to these questions in the description box. Thank you so much for staying with me. As always, questions and comments are welcome. Until next time, bye.